Now let's look at meningitis. Meningitis is a highly contagious disease of the meninges. The meninges become inflamed and then it causes problems. So let's take a look at the different types of meningitis that we have. The first one is bacterial. The bacterial is the most deadly form of meningitis and it can kill patients very quickly. So it is the most, it's not as common as viral, but it is the most deadly and has the highest mortality rate. The next one is viral. Viral is the most common and it can be recovered from. So it may take a while, but viral meningitis is not as severe as bacterial. Ways that viral meningitis is contracted through influenza organisms, HSV, herpes, mumps, West Nile virus, and then GI infections, also called enterovirus infections, infections that get into the GI tract and then get into the central nervous system through that way. The next one is fungi. Fungi infections are mainly found in AIDS patients. So if a patient presents with fungal meningitis, they'll probably test them for HIV. The next one is parasitic or parasites. So parasitic meningitis comes from organisms, parasites that are found in dirt, feces, animals, or raw food like fish and poultry. That's why you should always cook your food completely before ingesting in case there are parasites there. Another parasite that you may have heard of is the amoebic parasite that is found in lakes and fresh water. So what it does is it enters the nose through swimming in contaminated lakes, and it enters through the nose, which is very close to the brain, and it transfers into the meninges and it causes meningitis that way. So bacterial is the most deadly, viral is the most common. Fungi usually only occurs in immunosuppressed patients like HIV and AIDS patients. Parasitic is not as common, but it does happen. Now, let's look at our signs and symptoms. So the patients, when they arrive, they'll probably come in through the emergency room because they'll have a severe headache, fever, fatigue, and a stiff neck. Your clues into recognizing meningitis are stiff neck, headache, fever, nausea, vomiting. Okay, so if your client or patient arrives and they have a stiff neck, high fever, nausea, vomiting, headache, and they may have some mental changes like confusion, you immediately put them on isolation and on droplet precautions. Droplet precautions includes mask, gown, and gloves. So it's airborne disease, so we will put them on these droplet precautions because it can be transferred through respiratory secretions and coughing. It's important to know that you can recognize the classic symptoms: stiff neck, headache, severe headache, fever, and nausea, vomiting. Okay, it can appear to be the flu. It has that same viral type symptoms, but we got to recognize the stiff neck is a little different than the flu. And then we'll have to put them on isolation immediately. So remember that, okay? Other symptoms are photophobia, so sensitivity to light. Petechiae rash is kind of a late symptom. So they'll have these little splotches of broken blood vessels at the surface of the skin. It looks like little dots. Petechiae rash is a viral rash. They'll have a hyperactive reflexes, so Brudzinski's and a Kernig sign. They'll also have a change in mental status, so that would be like confusion, irritability, those type of things, that disorientation. Now, because of the severe infection, they may also have tachycardia, a fast heart rate. I also want to point out that stiff neck is often referred to as nuchal rigidity. So make sure you remember that terminology for another saying for a stiff neck is nuchal rigidity. And you may more commonly see this terminology than stiff neck. Let's look at what these hyperactive reflexes are. So the first one is Brudzinski sign. So positive Brudzinski's is when you have a forceful neck flexion, you bend their neck, and it causes their hip and knees to flex in too. So here I drew a little picture. So you bend their head down or up, or you bend their head, flex their neck, and their hips and knees also respond in the same way. They flex towards. So positive Brudzinski's neck flex elicits a knee and hip flex also. The other one is a positive Kernig sign. So positive Kernig sign is when the patient is laying flat and you bend their knee up and they can't extend their leg all the way up because it's very painful and they resist you. So a positive Kernig sign is extreme pain when you flex their knee but they can't flex their leg all the way up. So it elicits pain. So here I got a little man down here and he's laying down and he says, ow, because it hurts. Another way to remember Kernig sign is that the patient can't kick you. So if they can't kick up, they can't kick. Kernig, it kind of sounds the same. Both start with a K. So maybe that'll help you determine which one's which. Now let's look at diagnostic tests. So the most common thing they're going to do first is the lumbar puncture. So let's talk about the lumbar puncture first. Position the patient laying on their side laterally and have them bend in like a cat. They want to arch their back and spread out the vertebrae really wide, so it's easier to do the lumbar puncture. Or you can set it up like a pregnant woman who's getting an epidural. It's the same type of setup. So sit on the side of the bed and lean way over onto a bedside table with pillows or something, but you want their back to be arched. So that's the two positions that you can put them in. Laying on their side and curved in like a fetal position, or on the side of the bed leaning over the table with an arched back. Okay, the physician will do the procedure. There's not much nurse will do during the procedure except provide patient comfort and safety. Okay, so after the puncture is finished, you'll put a sterile dressing over the wound. It should be just a needle prick, so it shouldn't be really bleeding. You may see a drop of blood, but other than that, that's all you should see. Okay, so after the procedure is over, we will lay down, recline for 6 to 8 hours afterwards, okay? That is because we just took out some of the cerebral spinal fluid for testing, and it can make a drop in the amount of cerebral spinal fluid, and it can cause a headache. So if we just want to try and ward off the headaches that would come. However, these patients who have meningitis may already have a headache, so it may just make the headache a lot worse. So you will recline for 6 to 8 hours afterwards, and then we will increase fluid. So the more water you drink after this procedure, the more cerebral spinal fluid you can make, and the better that they'll feel. So increase fluids, and then if this is in general nursing care for the lumbar puncture procedure, not necessarily related to meningitis, but if the patient does develop the spinal headache is what they call it, so a severe headache related to the lumbar puncture procedure, they can do what's called a blood patch. So a blood patch is where they take venous blood, like out of the arm, venous blood, 20 to 30 mLs, and they inject it into that space where they did the lumbar puncture. And it helps seal the cerebral spinal fluid leak. Therefore, it will allow the body to rebuild the cerebral spinal fluid and help get rid of that headache that they have. Okay, so we're going to look at the cerebral spinal fluid. When you pull the cerebral spinal fluid out, it should be clear. Clear is the normal color, clear and odorless, okay? In meningitis, you can have clear fluid. Also with viral infection meningitis, it will be cloudy if it's a bacterial infection, okay? Now, the other findings for the cerebral spinal fluid will be increased white blood cells and increased protein. They'll also see an increase in the cerebral spinal fluid pressure. And then with bacterial meningitis, we'll see a decrease in glucose. Now, bacteria loves to eat glucose, so they're going to be eating up all that glucose. So bacteria will have a lower glucose level than normal. Now, other things we will do is a blood culture in case this is an infection in the bloodstream, and they can become septic from meningitis depending on what kind they have. So a blood culture will be done. In general, remember that a blood culture, if you're going to do one, have one ordered, you have to take that blood from the patient before you give a dose of antibiotics. Because if you give antibiotics first, it will alter the test of the blood culture. So always do the blood culture first, then give your antibiotics. We'll also do a CBC. CBC is going to tell us, you know, if their white blood cells are elevated from infection, if they have a high SED rate or high inflammatory markers. So we're just going to get a general profile of the patient's well-being with a CBC. Now let's look at some of the complications that meningitis can cause. The first one is the most common, and that is increased intracranial pressure. Because of the inflammation, we may develop increased ICP, and we will do interventions that relate to that. So we will keep the head of the bed up, decrease environmental stimuli, no coughing or straining. And you can look at the other video for ICP to see all the other things that we should do, but those are the main ones. Next is syndrome of inappropriate antidiuretic hormone secretion. So this will cause the body to concentrate urine. So you'll have really dark concentrated urine and the body's retaining fluid. So we will then switch to fluid restriction with orders, of course, if that occurs. The other one is a septic emboli. So the body will make these little clots in response to the infection that's going on. And we need to watch out for DIC, so that's bleeding out of the orifices, the nose, the IV sites, bleeding gums, watch out for that. So it can cause strokes, cerebral vascular accidents, so be aware of, you know, the one-sided weakness and signs and symptoms of a stroke. And then also it more commonly makes DVT, so we're going to monitor their legs and their pulses and the color of their feet, bilaterally compare, and we're going to make sure that the patient is not developing DVTs from having the infection. Now let's review some treatment options for patients who have meningitis. It really does also depend on the type of meningitis that the patient has. So after they do the lumbar puncture and the blood culture and the other lab tests, they will then determine the course of treatment. So for bacterial meningitis, they will start with antibiotics, of course, and the drugs that you'd like to use are really strong: Rocephin, Clafrin, vancomycin. Those are some strong antibiotics that they will use. The other one that they'll do is dilantin or phenobarbital or some other sort of seizure prevention precaution medication. It also, like phenobarbital, also can be used for sedation. They may want to sedate the patient slightly, just depends on what's going on. But we got dilantin is going to be given to prevent seizures. The seizures are going to be from increased intracranial pressure. So as the swelling and inflammation keep going on, the illness keeps getting stronger, it can cause increased intracranial pressure, and then we will have the signs and symptoms of that and those problems on top of the infection. So increased intracranial pressure can cause seizures, so that's why we're going to prevent them. Decadron is for the swelling, the edema, and the brain and the meninges. It goes back to increased intracranial pressure as well. Decadron is a drug of choice for brain swelling and anything in the spinal cord swelling. It's our corticosteroid that we will give. The other one is pain medications. So it's painful. They have that headache, that severe headache. They also have the fatigue and body aches maybe too. So pain meds, but we cannot give opioids because opioids constrict pupils. And we don't want that to happen because we need to do neuro checks and check their level of consciousness, and that includes pupil checks. So we're doing the pen light and checking their pupils. We want to see their pupils constrict. We don't want to have artificially made pinpoint pupils because of opioids. So therefore, we won't give any opioids for these patients. The other one that we will do, or the physician will do, is treat the family prophylactically. So whoever has close contact with them, remember, is highly contagious and highly infectious, so they will be treated prophylactically as well. Moving on to nursing care. So the first thing we're going to do is immediately recognize the signs and symptoms of meningitis: the stiff neck, the headache, nausea, vomiting, fever. We're going to put them in isolation immediately, institute PPE use for droplet precautions, mask, gown, gloves. Then we will also report this disease to the health department at some point during the stay and within the initial period. It needs to be reported to the health department because it's an infectious disease that's highly contagious, and they have to notify other people who have been in contact with the patient. Okay, we will also give IV fluids to maintain hydration because they will have had some nausea, vomiting. We have to also watch out for that SIADH complication. So if they start to retain fluid and they start to have really concentrated urine, then we will know to notify the physician when their urine output starts to decrease off. Okay, so antibiotics if they have the bacterial kind, anticonvulsants to prevent seizures. This goes back to increased ICP complication. Reduce their fever. So they will be feverish, usually high fever for viral. Okay, so if they have a fever, we want to decrease the fever because hyperthermia fever can cause increased ICP. It can make it worse. So we want to decrease their ICP. So reducing their fever, cooling blankets, Tylenol, that will help. Okay, neuro checks every 2 to 4 hours. Neuro checks is going to assess their level of consciousness, their pupil reflexes, their motor and sensory response. We want to decrease stimulation. So also no coughing, no straining. We want to make sure we maintain that normal intracranial pressure of 10 to 15-ish range. And we want to make sure that they don't go into increased intracranial pressure. We want to educate for vaccines. So there are some vaccines. I'll talk about that in just a minute. Seizure precautions. So patting the side rails, making sure that they're safe if they happen to have a seizure. Providing those anticonvulsants will also help. Vaccines. Okay, so vaccines we know are for viruses, but there is a vaccine for bacterial meningitis. So it's very strange and a backwards way of thinking because we're used to thinking that vaccines are for viruses like polio or, measles, mumps, rubella. Those are all viruses. But looky here, bacterial meningitis has a vaccine. There's a couple of different kinds. The HIB is for infants. Those are the ones that infants get when they're babies. The PPSV is the one elderly get or immunocompromised adults. Then there is MC4, which is most commonly given, besides the infant one, for teens, college-age students, especially ones living in dormitories, and then the military. If you notice, these age groups or these populations are always very close together in close quarters, where it's highly contagious to pass something and easy to pass something from one person to another. So this is very much recommended. It's not, some colleges require it if you're going to be living in their dormitory rooms, but it's very important. I used to work in a vaccine clinic and I would go around to different colleges like SCAD and Armstrong, and I would be the vaccine nurse for the day, and I would give all the students who were on campus who wanted it, and the ones who lived in dorms had to have the MC4 vaccine for bacterial meningitis. So it just helps decrease the amount of infection rate that they would have in their school. So it is highly recommended for these populations to get the MC4 vaccine. Let me ask you, if your client comes in and they show any signs of meningitis, what will you do first? Do you know? I hope you thought about putting them on isolation. Before you do anything else, before you take their vital signs, before you do their interview, they come in and complain of, stiff neck, fever, nausea, vomiting, immediately isolation precautions, gown and glove yourself up, mask yourself up, and then do what you need to do. Also put a mask on the patient as well. Okay, so remember to always think safety first. When you have an infectious, contagious disease, you've got to protect the safety of everyone else before you can really treat that patient too. So you have to think about both, and the fastest way to do that is to go ahead and put them on isolation, and you protect yourself so you can continue caring for that patient. Now, very similar to meningitis is encephalitis. Encephalitis mainly does more to the brain tissue, the white and the gray matter, and the meninges also. Swelling of the brain and the meninges, it's a viral illness caused from vector-borne diseases like measles, or vector-borne is the mosquito-based illness like West Nile virus that can cause encephalitis. And then sometimes it is an abnormal response to vaccines in children. So it's one of those little tiny fine prints that says may cause encephalitis, but it's not very common, it's very rare, but it's one of those things that you just have to say it. Okay, so let's look at our signs and symptoms. So what signs and symptoms are going to be so similar to meningitis. So how can you tell them apart? Okay, so let's look at what's different, okay? So we have sudden fever, whereas the meningitis is not described as sudden fever, but encephalitis is sudden fever. Like all of a sudden they just develop this fever out of nowhere. Severe headache, just like meningitis. Vomiting, just like meningitis. Stiff neck, just like meningitis. Decreased level of consciousness, meningitis too. Paralysis also happens in meningitis. So if meningitis is not taken care of quickly, they can have permanent damage to their meninges and nerves, and they will have permanent paralysis if they don't get it treated. And that's mainly with the bacterial, not so much the viral one. So paralysis is always associated with encephalitis, okay? Visual changes is specific to encephalitis, not so much to meningitis. And incontinence, so incontinence with their urine, okay? So these are kind of things that go along with paralysis. So these are the different ones that makes encephalitis different than meningitis. Let's look at our nursing care. There's not much for us to do but monitor them. It is always a virus with encephalitis that we're talking about. So nursing care, we're going to watch our vital signs. We're watching for signs of shock or increased ICP, which would be your Cushing's triad. So you would have a high systolic blood pressure and a low pulse and irregular or low respirations. Level of consciousness, we're going to do the neuro checks with this group of people as well. I's and O's, we're going to watch for a decrease in output that goes with the complications like SIADH too. Bowels and constipation, so we're going to watch for constipation, and that goes back to paralysis, and incontinence would be with the urine, so they can't have any control over their urine coming out, but they are not doing any movement, so they're not going to have good bowels, so they'll have paralyzed symptoms, and they'll have constipation. So what kind of treatment do these patients get is almost exactly the same as a meningitis patient. So they're going to get the medications to prevent seizures, anticonvulsants, they're going to get some antipyretics for the fever. We want to keep their fever down. They're going to give other supportive treatments will be corticosteroids for the swellings like Decadron. So it's mainly all the supportive stuff to help wait it out and hope that they recover fully from this illness.